Okay, I think we're official. I heard the recording in progress start. Thank you so much, Maureen. I appreciate Maureen so much for what she does. She's our amazing outreach coordinator here at Elder Care Management and largely responsible for not only promoting, but putting together these community education opportunities for us. So we appreciate all of what Maureen does for us. You can see that we are here today to talk about navigating the emergency room and hospital, and in general advocacy in the hospital setting. And I think that's a word that you will hear me repeat throughout today's presentation, because advocacy is really where it's at when it comes to navigating the acute healthcare system of the emergency room and the hospital, especially for older adults and their families. So if there was one word I could seize on today as the theme for what we're going to talk about, it would be that word, advocacy. So we have a little bit of a roadmap here that we're going to use to help guide us through this discussion. We'll talk about when it's time to go to the emergency room. How do you know? What's the difference between seeking help in the emergency room, the doctor's office, the urgent care? And how do you make an assessment when you're feeling like you're in crisis or your loved one's in crisis? With the advent of and onset of COVID, that became a even more complicated question. So a little bit more relaxed now, but definitely still on everyone's mind. So we'll talk about what to bring other than yourself, and why it's important to think about that ahead of time and how it might impact not only your loved one's experience or your experience as a patient in the emergency room, but could lead to better outcomes when you think about what to bring in advance. We will touch on the impact of COVID-19 and how that has changed emergency room and hospital experiences, and how we can deal with those challenges. You know, it's just become a reality for all of us, and I think we're all tired of it, but it's still there, and especially when we're working with older adults, it's something we've got to be especially cognizant of. In the medical setting, of course, they're still very vigilant about how they deal with COVID and how they deal with patients and people coming into the medical environment. So if you've been in a doctor's office, you know, you've still got to wear a mask, even going to the dentist. So the emergency room is no different. So we'll discuss that impact of COVID-19 and its ongoing impact. We're going to talk about what to expect when you arrive at the emergency room and how to navigate what to expect. And again, how to be best prepared for what you might meet upon arrival. We'll talk about treatment and diagnosis, how that happens in the emergency room, how it's different than treatment and diagnosis outside of the emergency room in the hospital, and why that's different. And that has to do with the whole dynamic and purpose and existence of the emergency room setting especially. We'll touch on admission to the hospital, and specifically some billing issues that can creep up. We'll talk about how to communicate with admissions staff, hospital staff, people who are caring for you or your loved one, and how to maximize and best understand the experience of being an inpatient in the hospital. And then we'll talk about discharge and how to come away from your experience in the ER or the hospital with the most and the best information that you can, and hopefully some better support and the tools that you will need for maximizing that experience and recovering from that. So so here we go. When to go to the emergency room. Obviously, if you have a life-threatening emergency, you think you're having a heart attack, you or your loved one, or a stroke, that's a no holds barred, no questions asked, 911 ER generating event. So our mantra is, when in doubt, get checked out. You think you might be having a heart attack. You think you might be having a stroke. You think something is life-threatening. Don't second guess. Make that call. If you wear a life alert of any kind, use that. That's what it's for. Sometimes things happen, symptoms creep up, people feel a little off, they're not sure, and they waffle back and forth about an emergency room visit. Should I go? Should I not? It's 5 o'clock. The doctor's office is closed. Should I wait until the morning? How do you navigate that? Well, if you've got symptoms of concern and there's an advice nurse you can reach out to, start there. Just don't wait too long to get a symptom addressed if it is persistent. We don't have, most of us are not clinicians. We don't have the medical background and training to make a formal assessment. We have to go off of some basic questions and cautions as we proceed. So again, we tend to err on the side of caution, particularly if there is a fall, and especially if it's an unobserved fall in a frail elder or an elder who has confusion and may not be able to report to us what happened. You know, we don't have X-ray vision, right? We can't see if there's an internal bleed or a brain injury or concussion. We can't assess the potential injury that might be underlying there. So when we have a client with a fall, especially if it's an unobserved fall, if there's not somebody on site who can do a comfortable assessment, we will tend to recommend that that person go get checked out at the ER and eliminate any concern that there is an underlying issue that's occurred. So head injuries are nothing to mess with, and fractures, other kinds of fractures can occur with falls. We've had clients in the past who had a fall, did go to the ER and get checked out, and things were missed and ended up with hairline fractures that later on were discovered that had been causing them problems. So, you know, we just, especially when you have a frail person or a person living with memory issues, can't report, can't necessarily respond to your assessment or the assessment of someone on site, again, and we recommend that's the time to go to the ER and get checked out. Another reason that older adults are commonly seen in the emergency room are an onset of confusion or change in mental status. What we mean by that is that you notice in your loved one that, you know, yesterday I visited and we had a normal interaction, and today they're very agitated. Or you get a call from a caregiver and they tell you that your loved one is really exhibiting some new or increased confusion. as care managers, we have learned and educated many of our families that these particular symptoms are often associated with a urinary tract infection and can be exacerbated by dehydration. So in our older population, staying hydrated is a big challenge. We're in a time of year right now where we're all working to stay hydrated, but year round, that is a challenge for many older adults, and it can contribute to urinary tract infections. In frail older adults, infection can cause these symptoms, and infection that's left unchecked can advance to something we call sepsis, which is a more system-wide infection, and that can be life-threatening and can be very difficult for an older adult to treat in an older adult and to reverse if it becomes too advanced. So one thing I would caution, I have had more than one client who tried to drive themselves to the emergency room, or their loved one who had fallen and had a laceration and needed to be repaired. You know, we sympathize with our folks who are cautious about the expense of an ambulance ride, but on the other hand, the costs associated with an injury that could be exacerbated because someone was transported in a car versus an ambulance are often far greater than the cost associated with that ambulance ride. So generally, if unless you have someone to transport you and you know that it's safe, again, we err on the side of call that the paramedics and have them come and assess and see what they think. So we always tend to counsel our clients, please don't do that. Please don't drive your wife to the emergency room in the middle of the night after she's fallen in the bathroom and has hit her head. She may be talking to you right now, but we don't have the ability to say that there's not something serious that's occurred here. So when to go to the emergency room, that's that in a nutshell. Understanding the parameters of the emergency room. I have no doubt that most of you have probably visited an emergency room and witnessed some of the unique challenges that it presents. So what we have learned is to accept ourselves as care managers, because we spend a lot of time in emergency rooms with families and clients, is understanding that it's not a place where we're going to get rapid service. So one of the things that we want to communicate today is if you have a medical condition or medical history that you know could land you or your loved one in the emergency room, educate yourself. Know the signs and symptoms to look for ahead of time. Know the changes that might occur if that condition is exacerbating, if it's kicking up its heels, so that maybe you can avoid that emergency room visit or be better prepared for that emergency room visit. You might be able to cut off at the pass an emergency room visit if you recognize on Wednesday morning that your loved one is increasingly confused and agitated. Maybe there is a urinary tract infection, and you can call your primary care provider and get the treatment, that the diagnostics and the treatment that your loved one needs without that emergency room visit. Same if you have, again, a medical condition. Maybe you have your loved one has a history of stroke. Be familiar with what the signs and symptoms of that are. Of course, if a stroke onset, then that's an ER visit. But other conditions that might have typically plagued them or historically plagued them. Be familiar so you can reach out for support in advance of or instead of an emergency room visit. So again, is there an advice nurse that you can call who's associated with your healthcare delivery system? Or is there an urgent care that you have familiarity with, or is this affiliated with your system that you might be able to access instead of the emergency room? So, and urgent care will let you know if they can address your need, or if they feel that your symptoms are more indicative of something that needs to be addressed by the emergency room. It's worth familiarizing yourself with other resources that are available that might be better suited. So again, that urgent care, that advice nurse, your primary care doctor's office, of course, during office hours. It's important to know that what differentiates the emergency room from those other resources that you might tap into is that the emergency room prioritizes life-threatening events. That's why it's called the emergency room. They really are they're going to try to tease out with what you present, the symptoms that you present with, what is life-threatening, and that's what they're going to zero in on, try to diagnose, treat, and either discharge you or your loved one or move you into an admitted setting in the hospital. So we're going to talk more about how the ER works and how they prioritize, but when it comes to understanding the parameters of the emergency room as opposed to other resources where you might access care, that is one of the defining factors of treatment in the emergency room, is they're looking at life-threatening events. Understanding that the emergency room has limitations. I was in an emergency room not too long ago, and I saw a family come in and they wanted to speak to a social worker for some support, and they were told there's no social worker here to address that. That is an outpatient need. Likewise, in the emergency room, you won't find services like occupational therapy, physical therapy, or specific equipment. That's not what they're there for. If you're discharged from the emergency room with a need like that, you're going to be channeled into a different system, different care delivery system for those services. But you're not going to receive those in the emergency room, not going to receive assistance with emergency housing placement or food or transportation or anything like that. They're very focused on addressing those events that, again, they feel are life-threatening. So understanding what the emergency room is there for, the parameters under which they operate. So what are you going to bring to the emergency room? What might you think about in advance that is going to help your stay there or your loved one's stay there be better, if it can be better in the emergency room? And this is where we bring in that advocacy word first and foremost and upfront. We, in our experience as care managers, because that is our role when we step through the door to meet a client at the emergency room, we recognize the importance of having someone to advocate for you. If you're the patient, you're in the emergency room because you're in distress. And even if you're a normally healthy person and you're not an older adult, a frail older adult, if you're in distress in the emergency room environment, you probably know how difficult it is to remember maybe everything that happened that brought you there, or your health history, or the myriad other questions that are going to be thrown at you. When is the last time you had something to eat? When is the last time you had a bowel movement? When is this? When is that? What is this? What is that? Having and then taking in all the information that's going to be given to you at the emergency room. Having an extra set of eyes and ears, someone to scribe for you, someone to help be your historian, and especially in the event that you're in pain and you can't communicate well. Nothing is going to replace having an advocate there with you. We like to encourage people to think in advance. What is some pertinent personal information that would be helpful to have at my fingertips in case myself or my loved one need to go to the emergency room? So Maureen has got a little, what we call my personal toolkit that we've assembled, and she can share a copy of that with you at the end of the presentation. But essentially, we're going to go through what that includes here. And of course, you can always add information to that that's pertinent just to you or important to you or your loved one, especially as it revolves around particular healthcare issues that you deal with on a chronic basis, medications you take, and so forth. So at the top of that list would be, what is your advanced healthcare directive? Because remember, the emergency room is for dealing with what? Life, challenging, health challenging situations, life-threatening events. So what better place to need to have what your healthcare wishes are? Those get expressed a few ways. The first is with a general advanced healthcare directive. This is a multi-page document that you can download a copy of online. We have them available as well. They don't have to be completed by an attorney. They're pretty straightforward. They state what it is you want when it comes to your healthcare, especially whether or not you want to be resuscitated if your heart has stopped and you're not breathing. They can speak to what kind of interventions you want, what kind of life extending measures you want, what kind of medications you can't, don't want, whether or not you want artificial nutrition and feeding, artificial hydration, all of those. So advanced healthcare directives can speak to all of those things. The general advanced healthcare directive just needs to be signed by the patient and two witnesses who are not related to them. It doesn't need to be notarized or anything like that unless you are a resident in a skilled nursing facility, then it does need to be notarized. For a lot of our older adult clients, or especially for those of our clients who live at home alone, we advocate something called a POLST, and we're going to talk about that in a few upcoming slides, and I'll show you a picture of it. The difference between an advanced healthcare directive and a POLST is that a POLST, which stands for Physician Order for Life-Sustaining Treatment, a POLST is signed by your physician, a physician. It works in tandem with an advanced healthcare directive. We like to think of the advanced healthcare directive as the guiding document and the POLST as the action document. It travels with a patient from where they live at home, all the way across the medical healthcare delivery system and back again. It's a portable document, and it has to be honored because it's a medically enforceable document. Whereas an advanced health care directive, usually being a multi-page document, is just a guide. It's a reference point. It's not something that's been signed by a physician. You're going to have to, if that's the sole document that you have, likely going to have to submit that and probably sign other directives within each healthcare delivery system that you find yourself. So again, we'll talk some more about the POLST in an upcoming slide, and we'll show you a picture of it. Next, and equally as important to bring with you to the emergency room is a current list of medications and a current list of chronic medical conditions, and emphasis on current with the list of medications. For our clients, we always recommend that that current list of medications is posted at home, right in the same place as their advanced care directive, meaning they're pulsed, so that in the event that 911 is called or they're taken to the emergency room, that those two bits of information are available readily in tandem together. A current list of medications communicates so many things to medical personnel. It communicates likely the medical conditions that you're being treated for and how, right? And they're going to want to know when's the last time you took your medications. So if you don't have that list with you, less likely to have that information available. But if you've got that list and it says that you take this medication 3 times a day, and it's this time of day now in the emergency room, they're going to have a better idea of what you have in your system, which is going to influence the treatment perhaps that they're going to be able to give you. And also their ability to continue to treat or address the medical conditions that you have in addition to what brought you into the emergency room. So can't emphasize enough a current list of medications. We recommend to folks that you have a little card that you keep in your wallet or, in our digital age on your phone with that current list. So, various ways that you can carry that information with you. There are registries now available where you can go online, post your advanced healthcare directive, keep a current list of medications, and that can be accessed by both your loved ones or a medical system. So don't necessarily rely on your medical system to always have a current list of medications. I help monitor, I have my own electronic medical record, and I help keep track of information for various clients on their electronic medical records. And pretty regularly, excuse me, pretty regularly, we are updating medication records in those systems. So don't necessarily rely on those to convey the most up-to-date information. You are really the best person to do that. Known allergies, do you have any? Those are important, especially in emergency care. So if you have one that's especially critical, consider a way to convey that either with an emergency bracelet or other means. And for sure and certain, have that allergy noted on your advanced directive, okay? Your insurance information and identification, again, your phone is a great place to snap a picture of that in addition to your wallet. I've never seen insurance information be an impediment or the lack of insurance information be an impediment, but it's certainly good to have just assembled with your other information that you keep in the event that you need to go to the emergency room. We always, as care managers, like to have copies of those things for our clients so that we can access them easily in the event that a client winds up in the emergency room with no identification or anything else. So a copy of your vaccination card, and by vaccination, I mean, of course, COVID, both for yourself and the person who is accompanying them. I was in the emergency room recently, was not asked for a copy of my card or the person who I was accompanying. So, but policies vary by hospital. We carry copies of our cards on our phones now, and but it's just good to have in your pocket in case you're asked. And then finally, some pleasantries. These seem like pleasantries, but boy, I'll tell you, when you are in the emergency room at 2 a.m, warm clothes can make the difference between a tolerable experience and a miserable experience. You know, they're sometimes generous and will hand a companion or an advocate a warm blanket along with a warm blanket for the patient. However, I can tell you, I've been in the ER with clients before and they're out of blankets. So they're rationing them and they're not handing them out to companions and advocates. So as care managers, most of us carry a little sweater or something extra in the trunk of the car, just in case we get that call on a warm summer day when we're in our little short sleeve shirts and we wind up in the emergency room with a client where it's chilly. So, you know, having a little, if you're living with or caring for somebody who's likely to have an emergency room visit, or you just think that it's probably in your future somewhere, it's okay to have a little bag that maybe you keep in the front hall closet that's got an extra sweatshirt in it and a couple of these things. So a water bottle is really nice to have if you're an advocate and / caregiver companion. Of course, your loved one or the patient, don't give them anything to drink unless you have the permission of a medical staff there, because they're probably going to restrict that while they're doing tests and running their diagnostics. But a little snack in your bag is not a bad thing either. 6, 8, 10 hours is not unusual in the emergency room. As a care manager, I'll look for an opportunity. Maybe my client is taken off for an MRI. I sneak out, use the bathroom, have a drink of water, and eat my granola bar, so I'm not eating in front of my client, but that can sure recharge your batteries when you need it, give you a little bit of a boost and help you finish out that long emergency room experience. So reading material, you know, most hospitals now, you can get on their Wi-Fi easily with your phone and lots of us, you know, have something to read on our phone. A phone charger is really critical. You know, sometimes you can find a sympathetic nurse or aide who, you know, will loan you a phone charger, but just carrying an extra one is a good idea, because you might be communicating with other family members about what's going on. As care managers, we're often communicating with responsible parties or healthcare agents or family members or even other medical providers about our clients and what's going on with them in the emergency room. So having that phone charger accessible, because, you know, it's always when we least expect it. You know, we had 20% left on the battery and now we're off to the ER. So that phone charger can be critical. All right, I promised you that we would show you a copy of the POLST. So here it is. And again, POLST stands for Physician Order for Life-Sustaining Treatment. It's always this beautiful bright pink, and there's a reason for that. This color was determined by its developers to be the most vibrant and noticeable because they want emergency responders to be able to locate it easily. They want it to stand out in a file, on a wall, wherever it happens to be used, whether it's in a patient's home or following them throughout the medical system. It's hard to miss that bright pink. So again, the difference between this and a general advanced healthcare directive is that this is a medically enforceable document. You can see down there toward the bottom in section D is room for the physician's signature. and then room for either the patient's signature or the signature of the legally recognized decision maker. Again, we always tell our clients, if you've got a post, it should be in a visible place at home. It stays with you. If we have clients who have a post, as care managers, we have a copy in our file, in our HIPAA compliant file. So let's take a look at the different parts of the post and what it addresses. So first and foremost, you can see there in section A, it addresses whether or not the patient wants to be resuscitated. So it says if the patient has no pulse and is not breathing, then do you want to be resuscitated or not? So if you don't, that's what we refer to as a DNR, do not resuscitate. If you do, then it says attempt resuscitation. If you select attempt resuscitation, then when you go to section B, where it talks about medical interventions, you must select full treatment. If you select do not resuscitate, you can check either selective treatment or comfort focused treatment. In order to differentiate what kind of intervention you want or your loved one wants, we encourage a conversation with your primary care physician. Medicare now allows for an office visit for this express purpose, so that you or your loved one can have a conversation with a physician who you are comfortable with to talk about how you want to complete this document. We recommend that if you have an advanced healthcare directive, the general form, that you take that with you as a reference. And there is actually a part on the form, on the post form here, that indicates that an advanced directive was referred to in the discussion. So again, recall that I said the advanced healthcare directive is a guiding document. The post, the physician order for life-sustaining treatment, is an action document. It puts into action your philosophy of care that you've expressed in your advanced healthcare directive. So moving down the form in section C, you can see it addresses artificially administered nutrition. And there are 3 choices there for you to discuss with your physician. And then there's the signature section. On the back side of the form, just a little bit more patient information. If there was a supervising physician, because this form can actually be signed by a nurse practitioner as well. And then there's room for an additional contact. For elder care management, sometimes we're the additional contact. We're not decision makers, but we certainly carry a lot of information and history about our clients and are in contact regularly with their families, their decision makers. So for some of our clients, we are that additional contact. So that's the nuts and bolts of the post form and how it augments the advanced healthcare directive. Well, we couldn't get away from this conversation, through this conversation without touching some more on the COVID-19 quandary. So we'll do our due diligence and give it the attention that it needs. So I think I already mentioned that I had an ER visit recently where I did not need to present my COVID vaccination card. But I have found that the hospital visitation policies are different. If you are walking in off the street to visit somebody, you're going to have to present your card, and you may even have to present your status, meaning you've tested recently. So just be familiar with what the hospital's status may be. And again, if you show up prepared with your card in the emergency room or the emergency department, that's most likely going to be sufficient for now. We have a a lot of experience with accompanying clients with dementia in the emergency room. We have sometimes used that during this COVID season as a way to get into the emergency room and help by helping assure staff that we can facilitate this process and help expedite it, because we are historians for our clients. We can help keep them calm. We can provide information for family members and so forth. So if you're find yourself in a predicament where you're being told, no, you can't come in, you can certainly apply that same strategy. So again, I think things have loosened up a little bit. It doesn't seem to be nearly as restrictive as it was, but there was a time in the last few years when we were able to employ that strategy. There was also a time when we were not allowed in, even with our clients who have advanced dementia. So that was very challenging for us as care managers. So we adopted a new strategy. We sat in the parking lot in our car. We made sure they had our contact information. We explained our role. We talked to anybody who would hear us. We got the name of the treating physician there in the emergency room. We got the phone number for the desk and the nurse's station. We still provided information, and it was accepted. That medication list, that information, that the healthcare agent's name or the family member's name. And then we let them know we'll be nearby. And we did our best to monitor the situation. So let's all hope we don't see a return to that with COVID or any other situation like COVID. But if you do find yourself in that situation, this is a good strategy. It's better than nothing. And we found that for the most part, staff would try to keep us updated. We usually had to poke and prod, call. We're still here, and you may have to do the same, but make sure that they know who you are, where you are, how to get a hold of you, and provide them with that information to show them that you're viable and helpful. And I think the COVID-19 quandary, as the slide is titled, really speaks to the importance of a written plan or the toolkit that we referenced earlier, and the availability of those documents, the Advanced Healthcare Directive, the POLST, and so forth, because getting copies of that information into the hands of medical personnel when you have to release your loved one, or in our case, our client, into their care, and you can't follow them into that emergency room or emergency department situation. Having those documents and that information readily available makes all the difference. So again, just being prepared. Okay. What do you expect when you step into that emergency room? Well, again, we know you're going to have to hurry up and wait. There's just no getting around it. The emergency room, the emergency department, because it's focused on acute situations, life-threatening situations, the whole process really boils down to that initial triage and them determining, depending on your history, your complaint, your vitals, the initial vitals that the nurse is going to check. They're going to determine where on their priority list you land. And that's going to dictate from there on out pretty much how the patient or you and your loved one flow through that emergency room system. The triage process is going to set you up, set the patient up for assessment. So let's say the patient comes in with abdominal pain, they're going to look at the pain scale. They're going to make a quick assessment, a judgment call about how life-threatening it is according to the vitals. And then they're going to begin to break down their assessment so that they can determine what tests they're going to run. And I think it's the tests and the waiting for the results of the tests that becomes so frustrating for those who are waiting. We happen to have on our staff here a nurse who recently retired from about a 17-year stint as an emergency room nurse. So she gave us some really important perspective in that she said, most people don't realize everything that's going on behind the scenes in the emergency room. You get isolated probably in a room with a curtain drawn across, and you hear hustle and bustle and noise going on in the emergency room, but you probably don't see it. Although I've been in the emergency room before, several of them that were so impacted that I stood in the hallway next to my client on a gurney and got to see a lot of things. I'd much rather my client and myself and you as the advocate be sitting in a room with a curtain drawn, so that at least you can have a little bit of calm and quiet. But Debbie, who's our retired ER nurse, she said, yeah, most people just don't know the time that it takes to get those test results. They have to be read and interpreted by a physician or a radiologist if it's scans and x-rays. And oftentimes there has to be consultations with other specialists who are, in different sections of the hospital, or maybe not even be on site. So phone calls and, other levels of consultation are going on even after test results are back, before you, the patient or the advocate, are getting any information. So just being aware that you're not the only one there. We all know that, but we all have an inherent sense of urgency when we wind up in the emergency room. We had that sense of urgency, and that's what landed us there, right? But we have to understand that there's likely someone else who's being treated whose need is greater than our own. And they're going to be bumped up in the assessment chain and the chain of care. So, I, as a care manager, I find that if I am polite, I get more information. If I'm helpful, but within boundaries. So, poking my head out periodically and, making an inquiry, or, waiting a reasonable amount of time before I ask, are the lab results back yet? Just letting hospital staff know I'm aware of the challenges that they're dealing with as providers, and I'm acknowledging that, but that I'm so grateful that they're coming in and checking in on my client. So, so as an advocate, be patient and polite, but don't be afraid to ask for what you need. So one of my goals as a care manager when I meet a client in the emergency room is, I'm not the physician, I'm not the clinician there to treat. I'm there to impart the information that I have. And I want to try to keep my client comfortable as possible and calm, because how difficult it is for them to be laying there on the gurney, on the bed, in the triage area or in the holding area. And maybe, they're in pain, or they're confused, or they're agitated. And I want to keep them comfortable. So what do I need to in order to do that? Maybe I need to ask nursing staff, could I have a warm pair of socks? Maybe they came in without any, or do you have we need an extra blanket. She's really, really cold. In fact, do you have any in the warmer? So, or if they come in and they need a little assistance with the client, maybe they communicating or whatever it is, I'm offering to assist in a manner that not transgressing their roles and their duties, but offering that assistance. And I often find that the hospital personnel, all of them are very happy, even especially if a patient is confused. I'm very happy to have an advocate there who can calm and quell and interpret and provide information and so forth. So I wish I could say that hurry up and wait was not the bottom line at the emergency room, but it is. And so the better prepared you are and understand that there is a lot going on behind the scenes, the better, and trying to quell your own frustrations so that your loved one, the patient, doesn't pick up on that and react to that. So diagnosis and treatment. This is kind of where the nuts and bolts begin to happen in the emergency room and hospital. Diagnosis and treatment plan. You want to be dialoguing with the medical providers, the nurses and the doctor, taking notes, asking questions, fielding information. If there are, and most likely there's going to be lab work done, ask for a printed copy of those test results. Most especially if you're in a hospital that's outside of your normal healthcare delivery system. But even if it is, sometimes those test results aren't easily accessible or readily accessible. And you might want to have your hands on them for the next step in your care, your loved one's care. So important to remember that because hospitals are that acute care setting, they're going to treat what brought you in. Okay, they're going to treat what brought you in. That's going to be their primary focus. They're going to be aware of other chronic conditions because you're going to have told them that you have those chronic conditions, and they're going to see your medications. But they're going to only address that fall and the 7 stitches on the back of the head, or that fall and the dislocated shoulder, or the urinary tract infection that caused the increased confusion and agitation. Okay, so they're not going to address any other problems that brought you in. It's most important that you follow through with the recommended follow-up. Why is that? Because it gives your primary care provider time to explore further what landed you or your loved one in the emergency room. It gives them an opportunity to document the incident, because don't assume that the emergency room will tell your primary provider that your loved one had a urinary tract infection. It may end up eventually in their medical record, but that doesn't mean that the primary care provider will see it. It's also a way to ensure that there are no complications. As care managers, because we handle so much healthcare interaction with our clients, we've all seen examples of this. I cited one earlier with an undiscovered fracture. The fracture was not in the pelvis area, was not discovered during the emergency room visit. But a few days later, with the primary care follow-up, the primary care doctor realized something's just not right here. And so back we went for more diagnostic tests. So, when they say, see your doctor within so many days, don't dismiss that, take it seriously and get it scheduled right away. So when you're home and as soon as doctor's office is open, get that scheduled. It also gives your primary care doctor an opportunity to discuss prevention, whatever kinds of preventive measures are relative to the incident or whatever landed you in the emergency room. So for example, that urinary tract infection, maybe you need to talk more about prevention measures. We deal with urinary tract infections regularly with a lot of our clients, and we share strategies. Oh, this doctor suggested this, or this really worked well for this client. Have you suggested that, or have you asked about that? So, you know, it seems like a kind of a minor thing, but it could be a major thing. Those urinary tract infections, and when you find a strategy of prevention, it's a celebration because we've just seen the effects that it can have on our clients. So that primary care follow-up, very, very important. Copies of test results, very important. It's possible that you'll be admitted to the hospital. We're going to talk some more about that in a few slides. But most emergency room visits often end up in discharge to home. So make sure you've asked your questions, you understand what the diagnosis was and what the treatment plan is and so forth. So again, pointing to the importance of having an advocate, being an advocate, so that you're collecting that information and you're utilizing it and making the most of that ER visit. So, all right, well, dementia and navigating this clinical setting of the emergency room. This is probably where care managers, especially, we rise to the occasion. I've seen care managers on our staff who it's not even their on-call night, but they've got a beloved client who's headed off to the ER, and this person happens to be one who's living with dementia, and they're just called to task to be their advocate. So it's probably one of those circumstances that speaks to utmost importance of advocacy in this setting. The reason being is that our loved ones, our clients who are living with dementia, are not good historians for themselves. They can't understand and adapt to the clinical setting the way the rest of us can. So we're tasked as advocates to do that for them. And we do that by being their historian. What does it mean to be a historian for someone? Well, first bullet point, inform the staff about their limitations. The staff see someone come in who's fallen and has a gash on the back of his head. This is my own client I'm speaking about here. Gentleman who is living in a small memory care setting. Staff were helping to bathe him. He fell backwards, large gash, a sizable gash in the back of his head, clearly needed stitches. 911 called. He was transported to local hospital. I got the call as his care manager and met him there. He was already in triage, still on the gurney, and not sure he recognized me with his stage of dementia, but recognized that I knew him as I addressed him by name, put my hand on him, told him how glad I was to see him, and at the same time turned to staff, introduced myself, explained who he was, why I was there, and that I would be staying with him until all the way through. And what was particularly helpful to staff in his case was that My client has a history of using some pretty strong language to express himself. He's verbally pretty limited now, but when he's agitated or upset, he uses some pretty strong 4-letter words. And it doesn't matter if it's me or a caregiver or a nurse or a doctor. Whoever walked in the room was summarily told exactly what he thought. Not very many words, but some strong words. And I was able to help staff understand it's okay. It doesn't mean that he's in pain. It doesn't mean that he's upset. It just, that's what comes out when he needs to express himself, and no other words are there. So along with helping them, understand where he was coming from, what was his living situation, how did this happen, who were the decision makers, whom I was already on the phone with and staying in touch with. They were very appreciative of that. So again, this is where the rubber meets the road for care managers and advocacy, is most especially with our clients with dementia. And for you, if you're a caregiver or you have a loved one who has dementia, we can't urge you enough to ensure that if they have an emergency room visit, that you're there with them or someone is there with them who can advocate for them. One of the things that we can do as advocates in this setting and under these conditions is control the environment. Most of our clients who are living with dementia do not like noise or loud, sudden things happening. And they also don't like to be poked and prodded too much. The approach is important. So I can act as an intermediary and almost as a coach for nurses and doctors coming in. And the news travels pretty fast, I've found, in the emergency room among the staff, once I've communicated what my client needs and how they can be best approached so that the staff can deliver the care that they need. Often just dimming the light a little bit, making sure that curtain is drawn and there's not a lot of visual stimulation going on. Dimming the light, drawing the curtain, maybe a little music on my phone. Maybe we're looking at pictures on my phone. This client who I was just telling you about with the laceration on the back of the head was a horse lover. I know a lot about his history. So I just talked with him and elicited a lot of smiles, sat next to him with my hand on his, made eye contact with him when they were repairing the head and so forth, reassuring, and then helped with transportation home and made sure the discharge was appropriate, communicated with the staff and so forth. None of those things can a person with dementia do in that clinical setting. So again, helping the staff understand who that patient is and some tools to handle them to accomplish care is so important. For patients, clients who might find themselves with a longer stay, that especially one that might turn into, or looks like it's going to turn into an admission, we often recommend to families that you get an agency sitter, an outside a companion to come and sit with your loved one. If you need to go home and sleep, someone else can't come and stand in for you, that is a service that is available. We often will do that with clients who are, again, going to transition to inpatient, and we've maybe been there 8, 10, 12 hours, and it's just a matter of time now before they're going to be moved to the main floor, but maybe it's going to be a while, is enlisting a care companion through an in-home care agency for them, just so they're not alone. Especially if they've reached the point where they're now allowed to have, something by mouth, or they're hungry and they're thirsty, making sure that if they exhibit that they need to use the bathroom, or they need you know, a brief changed or they need a blanket, that someone is with them to continue along that line of advocacy. And also for you, if a doctor were to come in or a nurse come in and deliver some more information, you're not there to receive it, that there's someone there to record that. So navigating, again, the emergency room with a client or loved one who has dementia is a tall order. It's an important thing. And again, probably one of the most important areas of advocacy in the healthcare setting that we can encourage. All right, so let's say you've run the gauntlet and you're ready to discharge home from the emergency room. Can't emphasize enough again that you get copies of available test results. We spoke to that a few minutes ago because they may not be readily available in the electronic medical record, if at all. They don't always land in there. You want a good copy of the discharge summary with instructions for aftercare. And I'm not just speaking about that follow-up appointment with the primary care provider. I'm talking about any referrals that have been made. What's the diagnosis? What was your loved one treated with? What were they given? What kind of care was delivered? All of those things should be in the discharge summary. Also, any orders for follow-up care or assistance that they might need. Are they going to need home health? Is there going to be some physical therapy needed? Is there going to be wound care needed? Is there durable medical equipment like a walker or a wheelchair, a bedside commode, a hospital bed, anything like that that might be generated from a visit? All of that should be noted somewhere. You want it in writing, and you want to know how you can follow up and follow through on it. If your loved one lives in a residential facility for the elderly, an RCFE, that would be like assisted living or memory care, it's most especially important that if the emergency room physician wants them to have medication, for instance, an antibiotic for a urinary tract infection, that you get a signed order for that medication to present to the assisted living community. State of California has a lot of regulations. Among our favorite is that one. And the facility cannot administer the medication without it unless they have a signed physician order. Having the medication isn't enough. They need a signed order. If the prescription is sent through an electronic pharmacy and is going to be delivered to the facility, they still need a signed order. Otherwise, they will not be able to administer that medication. If you're going to be picking up medication, think that through. Who's going to pick those things up? Where am I going to get them? And so forth. So ask for assistance from the staff. Okay, if they need to direct you do they need to direct you to an all-night pharmacy? Is there one that has a drive-through? Is there one that has delivery? Might even be worth thinking that that's something that you think through as you're putting together your be prepared for the ER visit. Okay. What about help at home? Have you thought through what it would be like if you get your loved one home and you're not able to completely care for them? There's a couple of different ways to address that. Maybe it's just wound care and you can't do the wound care. The doctor can write an order for home health. It may not start right away. You may need to see the primary care provider first. But that's something that's always covered by insurance. It's generally short term. It will be a few visits every week. Maybe it's not wound care. Maybe it's a little bit of physical therapy after a fall. Again, that would be covered by insurance. But what about if you just need help getting your loved one to and from the bathroom? Maybe that's, or maybe you need help with bathing, or maybe you just need some rest. That would be called companion care or in-home care, and that's an out-of-pocket expense. That's not something covered by insurance. So be thinking, you know, as you're formulating what might lie ahead in the care that you're providing for your loved one. What kind of help is available? Do you have another local relative or close family friend who would be available to act as some help for you or auxiliary? What if you have to go to work, etc.? So just be thinking and knowing that there's a limited amount of help that's available and covered by insurance. Okay. Discharge, oh, here we go, staying in the hospital. Okay, this is, I want to talk to you about something that has been a thorn in the side of a few people, but which we as care managers have had to learn how to navigate and then want to educate you about navigating. And that's formal admission versus observation status. All right. When you're admitted to the hospital formally, you're immediately you're in inpatient status. But what we have found has happened at times is that our clients, our patients, wind up staying several nights in the emergency room, or looks like in the hospital, but they're not formally admitted. They're on what's called observation status. And observation status impacts what's covered by Medicare and whether or not a person can qualify for a skilled or rehab stay as part of their follow-up care. So observation status basically translates into services for patients who are sick enough that they can't go home, can't be discharged from the emergency room, but they don't quite qualify for admission. And the tricky thing is that as a patient, it can be difficult to know what exactly is my status, because you might be getting all the same care that somebody who is an inpatient is getting. In fact, under observation status, you can spend 2 nights or 48 hours in the hospital. If you're a patient or even a loved one, you might think, well, we've already been here 1 night. He must have been admitted, right? Not so. Again, you can spend 2 nights or 48 hours in the hospital under observation status. The difference is that your doctor hasn't formally admitted you. So until you're formally admitted, you're on observation status. There's a few reasons for this. You might need further monitoring, but you don't meet the standard for admission, okay? So observation care helps determine a course of action for your treatment, but it's considered outpatient by Medicare. Part B of Medicare covers observation status costs at only 80% because you're considered outpatient, whereas Part A of Medicare covers inpatient services at 100% after your deductible is met. So if you remain on observation status, you have a lot of diagnostic tests run, you see several specialists, and then you're discharged home, and you've only been on observation status, that's going to be covered by Part B, your Part B of Medicare, which is your outpatient coverage, okay? And again, only 80% of your costs will be covered. And costs of test costs and consultation fees can add up fast. So the other thing is that observation care, so that 2 nights of observation does not count towards the hospital stay requirement that can qualify a patient for a skilled stay or rehab care. There are 3 nights of inpatient care are required in order to qualify for the 100 days benefit for a skilled stay in a nursing home setting, where you would get physical therapy every day, nursing services, etc. And that's covered by Part A, but not if you've only been in the hospital under observation status. So what do we do to circumvent this? We'll always ask, have I or has my loved one been formally admitted? And you can start asking as soon as you have been there one night, what's going on, okay? If you're transferred or your loved one is transferred to a skilled setting, a nursing home, ask the admitting staff if Medicare is covering that stay, because they're going to know, right? Otherwise, that's going to be out of pocket. The hospital is responsible for giving you a Medicare outpatient observation notice if you've been under observation for 24 hours. Okay, so if you or your loved one have been in that emergency room or that hospital setting for 24 hours and you're not clear, they have to give you that outpatient observation notice. If you get that notice, you want to talk to the doctor immediately, and you want to ask him to formally admit you or your loved one. You want to ask the hospital for written notice explaining why they insist on keeping you or your loved one on observation status. And you want to ask for documentation from the physician showing why the admission isn't medically necessary. Okay. People are successfully appealing observation status issues. They can be cut off at the pass. We've been told, and it's hard to believe, but maybe not, a lot of physicians just don't understand the difference. They're there as medical providers. Their heads are full of treatment and diagnostic procedures, and they're focused on their patient. They're not as focused on the billing and the financial aspect of it, the insurance aspect of it. But there are people in the hospital who are, the discharge planners, the admissions folks. So go after that information if you have any hesitation. And it's okay to say, hey, are we here on observation? Right? So if you're there more than 24 hours, start asking questions. So observation status versus formal admission. So let's say you've cleared the hurdle and you are formally admitted. It's going to mean a new medical team. The ER doctor, the ER nurses, they're not going to follow you up onto the main floor of the hospital. You're going to have a whole new set of folks tending to your needs. Generally, the physicians who treat inpatients are called hospitalists. And you'll find that they work rotations of 2 to 3, maybe 4 days if you're lucky. You might catch a rotation that's just ending, meet a physician, and then the next day have a new one because you caught the end of a rotation. So again, this is where our advocacy really comes into play, because you're going to find the need to repeat yourself. Repeat to the nurses, repeat to the medical team, the doctors, repeat to the physical therapist and the occupational therapists. Who is your patient? Who is your loved one? What were they first admitted for? What's happened already? How have they responded? Do they look different to you than yesterday? Okay. I'll share with you a recent experience I had with a client, hospitalized for a particular reason, very medically complicated, but staff were focusing on clearing up the reason that he came in for, okay, doing a good job of focusing on that. But what happened in the interim? A previous problem, chronic issue that he had flared up. Nobody knew what to do with it. I got history from the family, conveyed that, etc., and had to convey it to several teams. I visited him one day, found him clear, visited him the next, found him not clear. New nurse on that day, had not seen him the previous day, didn't know that that wasn't his baseline. So again, really speaks to the necessity of advocacy, someone who knows the patient, being there, you know, at least for a daily check-in to provide insight, information, and promoting what that patient needs. In this particular case, they could not get him to eat. I stayed until I could figure out what it was he would eat, helped him eat, helped feed that appetite and stimulate it and get them going. So, but you know, the rotation of medical teams through that environment is regular and is another reason why it's so important to have somebody advocating for that patient. And our other bullet points speak to that. You want to get regular feedback from the staff about what treatment is occurring, because things will occur when you weren't there. Tests will be run, perhaps medications changed. So ask every time you're there, you know, have there been any new developments? Could you check the medical record for me? I'd just like to know what happened in the last, you know, 8, 10, or 12 hours. So just like in the emergency room, don't be afraid to ask. Be polite, be pleasant, but be persistent, and don't be afraid to ask for information, and don't be afraid to share. Don't be afraid to speak up. I think my loved one is different than yesterday. I'm concerned because he or she is not usually like this. This is different. Those are the things they need to know. All right, discharge home from hospital. So one of the people you will encounter, you and your loved one will encounter as soon as you're admitted, believe it or not, will be the discharge planner. Generally, the discharge planner will see you within the first 12 hours of an admission, if not sooner. And they'll start gathering information from you and your loved one. So it happens early on. It's actually a good thing. It's an opportunity to clarify concerns that you may have, ask questions, and so forth. It's a good opportunity to express that you may have concerns about limitations upon discharge. Let's say your loved one fell and broke their hip, and you've got steps at home, and you know rehab has to happen before you can return home, and maybe even some home modifications. Speak up right away to the discharge planner, because that's information that can be entered into your loved one's chart and become a part of their treatment plan and the plan for discharging them. So if you have concerns about limitations in your ability to care for them, they can share resources with you for other options. Maybe it's time to look for alternative placement or another setting, another level of care. Maybe that's because you're just not able to help them. You know, this is where planning ahead, thinking ahead, you know, considering your options is so important. If your loved one is going to be in need of that rehabilitation, again, they need to complete at least 3 nights in the hospital in order for that Medicare benefit to kick in. Most physicians and healthcare systems are sensitive to, aware of this, and understand the necessity of that. You certainly want your loved one to be stabilized at the very least before they're transferred to a skilled setting. And so, by the time medical personnel receive them up onto a main floor and medications are synchronized and they've exhibited a minimum amount of progress, at least 3 days and nights has gone by, but it's just a good thing to be aware of. Our rehabilitative stays in the skilled settings are definitely geared toward rehabilitation. They are generally 12 to 14 days. There is the option, the benefit is 100 days per period, but the average stay is 12 to 14 days. And the objective is to maximize efforts to restore them to a functioning where they can return to their previous setting. And the hospital discharge planners, if that's where you're headed, it's their responsibility to help with that skilled nursing facility transfer. It's their responsibility to check and see who your healthcare supplement or coverage, which facility will accept that, where there's space available, and then to hopefully give you some choices, some options about that. So again, those short-term stays are geared toward rehab and getting you restored back to where you can return, hopefully, to your previous setting. So if you're going home and there's durable medical equipment needed, physician orders are going to be written for that, and that's according to criteria that the physician stipulates. It's got to be related to your diagnosis, and for the most part, insurance is going to cover most durable medical equipment, but not all. The typical durable medical equipment is wheelchair walkers, and that's a front-wheeled walker, not a four-wheeled walker. Hospital beds, certain kinds of hospital beds. So, knowing your benefits, understanding what your out-of-pocket costs are going to be is important. There are medical equipment supply companies and stores where you can access just about any kind of durable medical equipment that you might need. You can certainly pay for it out of pocket. Sometimes families elect to do this for the sake of ease or convenience, or maybe they want a different level of medical equipment. Home health, we touched on a little bit. Often folks are discharged home from the hospital with home health. If you've been in the hospital for a week or more, chances are you're might need a little physical therapy, especially if you've had some surgery. Or let's say you had a stroke, or your loved one had a stroke, you might need some occupational therapy to learn how to, use again or perform some of your daily functions, or learn how to do them more efficiently with the limitations that may now exist. So home health is a Medicare and an insurance covered benefit, but it is limited. Generally, it's going to be, a 4 to 6 week proposition, a couple of visits a week, if maybe once by a nurse once a week, maybe twice by physical therapist or occupational therapist. We don't shy away from asking for an extension on home health visits when our clients have those, especially if we see that they definitely would benefit from an extension, and often those are granted, but you have to ask. They won't just summarily say, oh, we're going to give you another 2 or 3 weeks. But we've actually been able to push those benefits out quite a ways for some of our clients, as long as we can show, or they can show, progress. That's kind of the key. Once a patient plateaus with regard to physical therapy or occupational or speech therapy, once they plateau and they're no longer showing that they're making progress, generally, those services will not be extended. Wound care is an exception there, of course, because a wound is going to only progress so fast. We've had clients who had wound care at home for many, many months until wounds resolved. And wound care, it might stop for a few weeks, and there was no way that wound was going to be maintained without the regular care of a visiting nurse. So those are some circumstances under which home health can occur. Then there's supplemental care. We spoke to this a little bit. Supplemental care is going to be your out-of-pocket expense. This is going to be an in-home care agency who you would elect to contract with to come into your home. They would supply a caregiver who could assist with bathing, toileting, transfers, very light housework, some meal preparation, maybe some errands, things like that. But that's about where their role ends. They're not, in-home care providers are not allowed to dispense or give medication. They can't administer any kind of medical care, say an injection. They're not supposed to dress or care for a wound. They can help dress your loved one. They can help put those compression socks on. They can help bathe them. They can help them get to the toilet. They can help them get clean. They can help turn them in bed, but they cannot administer medications. And they're not supposed to perform any kind of medical care that a nurse would perform. So limitations there. In-home care runs between $30 and $34 an hour now. It's not an inexpensive proposition. It's not a solution for most people anymore to staying home and having needs met, but it can be a good stopgap measure after a discharge home from the hospital. And we often recommend that our clients employ this strategy when they're coming home from the hospital, especially if we have an older couple who are aging at home together and one returns home from a hospital stay. It's a tall order to place on an aging spouse to care for another person who's been discharged from the hospital. So they might wince at the idea of the cost of bringing in that kind of care. But if it prevents them from going down, it prevents them from becoming ill, if it helps their loved one heal all the better, all the faster, then it's definitely a worthwhile expenditure. And we encourage our seniors who have worked so hard, to save for this time in their life to think of that as, maybe that this is a temporary way to help restore you and bring you back to health, the two of you, not just, it's not just an added extra expense that's not going to be well spent. So that would be your supplemental care. Okay, who pays for what? You've got your insurance and co-pays and so forth and so on. Be familiar with your benefits. Understand, what is Medicare Part A? What is Medicare Part B? What is Medicare Part D? Part A, again, that is your inpatient care, talking strictly about your hospital benefits. Part B is anything that is done in the outpatient setting, whether that's your observation status, right? Your emergency room status, or your physician visits. Part D is is always elective, but that's your prescription coverage. So understand, then many folks have, supplemental policies to fill the gaps in what Medicare doesn't cover. So understand what your coverage is, what your co-pays are, ahead of time so that you can be prepared when you have these events that land you in the ER or in the hospital. Again, the criteria for a rehabilitative stay or a skilled nursing stay is that minimum 3 nights in the hospital. So that's a good nugget to plug away. If you are feeling really uncertain about the trajectory of a discharge, it can be appealed. This care managers particularly will appeal to a physician or a discharge planner to say this is an unsafe discharge. We are looking at a person who's been living alone, cannot return home. We need more time to put a plan of care in place, or we're working on placement, or we're working on, safe entry into the home, setting care up at home, whatever it is. So just know that a discharge can be appealed. We always ask, has a physical therapy evaluation been done? That is actually required for a discharge. That doesn't mean it always gets done, but you can say, we'd like another physical therapy evaluation. So don't be afraid to speak up. Again, a part of the advocacy role is to ensure that wherever your loved one or that patient, that client is being discharged to, that setting is going to be able to meet their needs. So what does Plan B mean? Plan B. Do you understand the limitations? Have you thought ahead and talked about scenarios, all of the what ifs? You're aging in place, or you're a caregiver, you're taking care of a loved one. Have you thought through what's going to happen as things continue to change? I have to tell you, I had a disheartening call just this week from someone, not a client. They had received our contact information. I think they did a web search. They were desperately looking for some help and passed it on to the family member who eventually reached out to me. She was calling about a family member who had a chronic disease process that was deteriorating and had wound up in the hospital for the last 5 days. And his wife, who has dementia, believe it or not, was there at the hospital with him the whole 5 days. And she kept, when she would get up to go use the bathroom, she'd get lost and staff were bringing her back. I've actually never heard of this happening for such a long period of time, but there was no plan B. This gentleman had been caring for his wife with dementia at home without a plan B, no support services. So when he had to go to the hospital, he had no one to call to come stay with his wife. This is probably one of the most extreme scenarios that I've heard, but a real case. And I just think it speaks to the reminder of why having a plan B is important. Are you a working caregiver? Are you a spouse with no supports? Are you living in a home that's not friendly to aging in place? Whatever it is, wherever you might find yourself, be thinking about what's going to happen the other side of an ER visit that ends up with a hospitalization or could impact you where you're at. Just be thinking, what does the future look ahead, and what is my plan B? Who's available to help me, and for how long? So, what's possible versus what is desired for both your loved one and your family and or their support system. Have those conversations. Sometimes we have to have them around the ones we love, or the person of concern. Sometimes we have to have them separate, just so that we're best prepared. But either way, we do need to think about what is our plan B, and how are we going to move beyond, this this and capitalize the best that we can on these events that have landed us either in the emergency room or in the hospital, in a skilled stay. Do we know the resources? Are we going after them? Have we equipped ourselves? What's in our toolkit, so to speak? And how are we going to regroup after this? So I've really enjoyed that you took the time to join us for this presentation, because it's one near and dear to my heart. I spend a lot of time, as I've said, as a care manager in the emergency room setting, in the hospital setting, the clinical setting. It's an area where I see time and time again the necessity of advocacy, of having somebody who can speak for you or on your behalf or on the behalf of your loved one. And I appreciate that you took time today to educate yourselves about the importance of that. And I hope that you found the information helpful. And I think we're going to open it up to questions now, and I will pass that over to, I think we'll see Maureen's got some questions in the chat box for us.
Yes, thank you so much, Felicia. So much information there and a lot for us to think about. The one question that we do have is, what happens if my loved one contracts COVID while in the hospital?
Oh, so we had this happen recently, actually, with a client. He had a fall, went to the emergency room, wound up having a hospital stay. And during the hospital stay, he contracted COVID. He was COVID free when he got there, but he wasn't after about 4 or 5 days. So he actually ended up, because he'd been in an assisted living prior to the injury and hospital stay, he was discharged to a skilled nursing facility that had a COVID unit. And he had to stay there until he tested negative and could be transferred then to a skilled setting where he did some physical therapy, and then eventually transferred back to his assisted living setting. So it depends on where you're coming from. If you contract COVID while you're in the hospital and your goal is to go home, then of course you probably still want to test negative before you go home. So it's just an unpleasant fact that, hospitals are germ factories, and we go there to get well, and we sometimes get exposed to other things. But the most complications that we've seen along that line would be for those clients who need to return to assisted living, and they absolutely can't until they have that negative test. And they often cannot stay in the hospital because they've maximized their treatment plan there. So then they are transferred to a special skilled setting where there's a COVID unit. Yeah, and it's very difficult for them. They they can't have company and visitors, and even as care managers, we can't go into those special COVID units. So we're really hoping that those things are going to become a thing of the past quickly.
Hopefully just a very rare case and worst
Yes.
case scenario that most of us don't have to deal with. So
yes,
thank you so much. We do invite you, if you have any additional questions, please feel free to email us, visit our website if you want more information about our services and what we do. And then please mark on your calendar to join us for our next presentation in September, when we will talk about Care Management 101 and delve more into our services and how we can support. So thank you again, everyone, for joining us, and have a wonderful evening.
thank you, everyone.